constrictive versus restrictive normal pericardium is a two-layered structure. Visceral pericardium and a parietal pericardium. Visceral pericardium is adhered to outer wall of the heart and parietal pericardium is outer fibrous layer. આ બંનેની વચ્ચે હોય pericardial fluid which is nearly around 50 ml and normal thickness of pericardial fluid is 2 mm. Some interesting fact, left atrium is not completely intrapericardial. All other chambers are completely intrapericardial. આની પર જ આખી physiology છે. Second important point is pulmonary veins are completely intrathoracic. It is not intrapericardial. SVC and IVC are generally extrathoracic structure, but the intrathoracic pressures are transmitted to SVC more as compared to IVC. So, આ બે પોઈન્ટ પર આખી ફિઝિયોલોજી ડિફાઇન થાય છે. Pulmonary veins are intrathoracic. LA is not completely intracardiac. Rest of the chambers are intracardiac. એટલે જ્યારે inspiratory variations થશે ત્યારે variations generally in normal case, normal person applies to everywhere. Intrapericardium, extrapericardium, all intrathoracic structures માં apply થાય. Versus constrictive pericarditis, જ્યારે હાર્ટની આસપાસ covering હોય of pericardium, then the pressure changes does not apply to intracardiac structures. એના પરથી આખા બધી ફિઝિયોલોજી ડિફાઇન થઈ ગઈ. Normal pressures. Pericardial pressures are normally -2 to -5. RA mean pressure is 5 to 6. LA mean pressure is 10 to 12. In constrictive pericarditis, all pressure will be similar because it's a closed chamber. So, the mystery of constrictive versus restrictive pericarditis is very difficult, and we need to, and both looks
page slide transfer પાસે increase decrease વાળી
क्या करो
બસ
આ જો ડિટેલ માં આવશે
ના થઈ
and both looks exactly similar and nobody has labeled them 1 and 2, so we have to label it. So basically it's a thick skin versus stiff muscle. A constrictive pericarditis is a thick skin. It's a thick and calcified pericardium which does not allow movement of heart beyond certain extent. It's a closed space, closed vault. Versus restrictive pericarditis, which is a stiff muscle, and because of stiffness of muscle there is diastolic dysfunction. So in both the case there is diastolic dysfunction. In constrictive pericarditis, diastolic dysfunction is because of impaired filling of ventricle, and impaired filling is secondary to constriction. It does not allow heart to expand. Versus in restrictive cardiomyopathy, per se myocardium is thickened and it does not want to expand, so there is a diastolic dysfunction. So clinical presentation wise, both are more or less overlapping to each other. By definition, constrictive pericarditis is pathological condition with encasement of the heart by a thickened, fibrous and sometimes calcified pericardium with secondary abnormalities in chamber fluid. Hemodynamics of constriction is the primary hemodynamic consequences of constriction is limitation of total volume of blood. LA માં વધારે LV માં વધારે વોલ્યુમ આવે તો RV has to get compressed, RV માં વધારે વોલ્યુમ આવે તો LV has to get compressed. So limitation of total volume of blood that can be accommodated by heart during diastole across the respiratory cycle, and there is equalization of right and left sided filling pressure during diastole particularly. There is very important concept of ventricular interdependence which applies to constrictive pericarditis, and it goes like this. During inspiration, when RV volume increase, now the total volume is fixed, so LV has to get compressed and septum moves towards the LVC. Actually it is opposite. During inspiration what happens? Intrathoracic pressure will go negative. This negative intrathoracic pressure gets applied to pulmonary vein which are extrathoracic structure, and pulmonary veins are not covered by thickened pericardium, so they can take negative pressure. So pulmonary vein venous pressure goes to negative side, and because of that negative pressure LA volume will decrease. Now blood flow moves from positive pressure to negative pressure or positive pressure to zero pressure. There has to be some gradient for blood flow. Now during inspiration when pulmonary venous pressure goes towards negative side, so negative pulmonary venous pressure with normal LA pressure, blood movement will not occur. So LA will not get filled and LV will not get filled, and because of low filling LV, septum get pulled toward the LV side, and that's why we get more space on the RV side, which which is being filled by IVC. Again, IVC is not even intrathoracic, not intrapericardial. So IVC pressure remains normal in constrictive pericarditis. So normal IVC will fill up the RV. So that's why septum will go or septum will shift towards LVC.
One thing to add, because negative intrathoracic pressure will shrunk blood from IVC and SVC.
Yes, it will
It will increase it.
Yes, so both the factor will happen, pulmonary venous as well as IVC pressure. So RV will get filled. That's why septum will move towards LV side in inspiration. Exactly opposite happens in expiration. During expiration, intrathoracic pressure will increase. This increased pressure will get applied to pulmonary vein, so that pulmonary vein empties into LA, LV, and LV will expand. And so the septum will move towards the RV side. This is ventricular interdependence. During inspiration, septum will move toward the LV side. During expiration, move toward the RV side. And this phenomena is exaggerated in case of constrictive pericarditis. And because of this, during inspiration, we get more of velocity across the tricuspid valve during inspiration versus more velocity across mitral valve during expiration. An important finding is that hepatic vein. In hepatic vein, during expiration when the septum moves towards the LV side, the RA will have a reversal of flow. So there will be diastolic reversal of flow in hepatic vein. Why diastolic reversal? Because IVC is still extrathoracic structure, it will remain congested a little bit. The RF filling will decrease because of the septum movement towards the RV side, and that will create a diastolic reversal phenomena. This is very typical of constrictive pericarditis. Actually, before advent of this tissue Doppler and speckle tracking, this was the only diagnostic criteria which goes towards the side of constrictive pericarditis. Coming to restrictive cardiomyopathy. By definition, WHO definition, restrictive cardiomyopathy is a disease of myocardium characterized by restrictive filling and reduced diastolic volume of either or both the ventricles with normal or near normal systolic function. So here the problem is with diastolic function only. Systolic function remains normal. If we define it further on the basis of anatomical, histological and physiological criteria, physiologically it's an abnormal LV diastolic filling. Histologically it is intracellular interstitial infiltration or fibrosis that includes multiple etiologies that I'll come in next slide. And there is abnormal LV wall thickness with absence of LV dilatation. Hemodynamics of restrictive cardiomyopathy is the result of abnormality intrinsic to myocardium which are unchanged during inspiration, because here the pericardium is not thickened, so all intrathoracic pressure will get transmitted directly to the cardiac chambers. And unlike constrictive pericarditis, there is no discordance between intrathoracic and intracapillary pressure changes. Types of restrictive cardiomyopathy, multiple. So in modern era, the restrictive kind of pattern is generally seen with elderly patients, patients who are having diabetes, and patients who are having radiation therapy in past, or some oncological disorder. Other causes are idiopathic, familial, hypertrophic cardiomyopathy can also have a subcomponent of restrictive cardiomyopathy. Then infiltrative disorders like amyloidosis, which is very common, sarcoidosis, fatty infiltration, even with developing metabolic syndrome. Metabolic syndrome is also one of the cause of restrictive kind of pattern. Storage disorders like hemochromatosis, Fabry's disease, not very commonly seen. Endomyocardial fibrosis, hypereosinophilic syndrome, carcinoid heart disease, not very common in our region as such. Radiation and toxic effects are also there. History wise, let's come to the approach. Generally, history also gives some clue. In case of constrictive pericarditis, many times patient is having tuberculosis in past. Although in Indian context, many of our patients had tuberculosis in past, but still, when patient is having tuberculosis, you are dealing with diastolic heart failure, keep it in mind, it could be a constrictive pericarditis. Radiation exposure. Even any cardiac surgeries in past, CABGs. Now this has picked up. In developed countries, the commonest cause of constrictive pericarditis nowadays is CVTS surgery in past. Connective tissue disorders. Any history of pericardiocentesis in past, or acute pericarditis equally. While restrictive cardiomyopathy generally pertains to some geographical area, particularly to southern region of India where eosinophilic myocarditis or eosinophilic restrictive cardiomyopathy is common. Metabolic syndrome, in nowadays recent era, metabolic syndrome has picked up as a cause of restrictive cardiomyopathy. It is the commonest cause as of now. Infiltrative disease like amyloidosis, sarcoidosis is also being picked up very frequently. So that also proves to be the cause. Metastatic cancer and radiotherapy also favors restrictive cardiomyopathy. So these are major causes. Minor causes could be many that already we have discussed. These are the major causes and you should keep it in mind during historical evaluation. Although, to add to the confusion, both constrictive and restrictive cardiomyopathies can coexist in same patient at times. Going to the physical examination. Symptoms. Generally, constrictive pericarditis have a abdominal distension because of fullness of IVC that leads to pedal edema. Ascites out of proportion to edema favors the diagnosis of constrictive pericarditis. And PND is usually absent because it's more or less right-sided symptoms. Versus restrictive cardiomyopathy, here PNDs are typically present. It's a both-sided problem. It's a LV as well as RV failure. And symptoms of RV failure are also present that leads to dyspnea, pulmonary venous congestion and all. Pulse, although it does not help much, but very rarely, in 1/3 of cases, paradoxical pulse will be present, that is decrease in pulse pressure or decrease in blood pressure during inspiration more than 10 mm of mercury. That is present in constrictive pericarditis. Although it's a very typical feature of cardiac tamponade, it's not very typical for constrictive pericarditis. It can be seen in 1/3 of constrictive pericarditis also. While in restrictive cardiomyopathy, pulse pressure remains normal. JVP helps. Kussmaul signs is usually present in constrictive pericarditis. Anyone want to comment on Kussmaul signs? Sorry, yes,
Inspiratory rise in JVP, sir.
Yeah, so inspiratory rise or inspiratory fullness of JVP is Kussmaul signs. It usually remains present, while Kussmaul sign remains absent. Why it happens? Because SVC is absolutely, IVC is absolutely extrathoracic structure. SVC still remains intrathoracic little bit. So because of that, inspiratory pressures or inspiratory negative pressure will suck the blood from the SVC. Although IVC is filling the RMO, so SVC remains stagnant, and that leads to increase in SVC or JVP during inspiration, and that is our Kussmaul signs. Frederick sign is also more or less same. Frederick sign is rapid descents, that is rapid prominent X and Y descent in JVP, that gives M or W pattern. While JVP does not help much in restrictive cardiomyopathy because it's a low filling state, so JVP usually remains normal or it is either low JVP pressures until unless late in disease where there will be high jugular venous pressures. CVS examination, there will be a S3 in restrictive cardiomyopathy as it's a diastolic failure, while in constrictive pericarditis it's a pericardial knock, which is again diastolic sound, because this ventricle which are underfilled will get empty during systole, and during early part of diastole, when there is longitudinal lengthening of ventricle, that will lead to sudden filling of the ventricle. That also gives rapid X descent, and that also gives pericardial knock. X-ray also helps many times. Rather than frontal X-ray, lateral X-ray helps. That shows your calcified and thickened pericardium. ECG constrictive pericarditis does not have any typical feature, while restrictive cardiomyopathy have low voltage ECGs and also biatrial enlargement on ECG. And very common, atrial fibrillation is very common in restrictive cardiomyopathy. So when you are doing echo, you find patient is in atrial fibrillation, that also should strike your mind that this could be a restrictive cardiomyopathy. So this is again JVP in detail. Extenuated early rapid ventricular filling occurs due to high atrial driving pressure and unimpeded ventricular relaxation, because ventricular relaxation is not impaired. It's a disease of pericardium, followed by sudden rapid rise in pressure from pericardial restraint. After certain filling, the pericardial pressure will suddenly increase. So this will lead to rapid wide descent, followed by again a straight plateau, which will give you a square root sign. Although diastolic pressures are high, there is paradoxically low stroke volume because the volume is always low. Pressures are high, but volume is low. So we will not go into detail of this GBP. It's confusing. This is XM. Lateral X-ray will show a thickened and calcified pericardium which is encasing the heart. And this can be seen in nearly 50% of cases, although it is not very specific, not very sensitive, but still, in view of other findings, in view of clinical history, in view of symptoms and in view of physical examination, this can induce us to diagnosis as a constrictive pericarditis. And persistent unexplained pleural effusion can be present in manifestation in case of constrictive pericarditis also.
Install the time lesser.
In computer got confused.
Confused એટલે તમે
CP
પછી
versus RCMP.
કન્સ્ટ્રક્ટિવ પેરિકાર્ડિટિસ નું
તમે
કઈ
PPT પ્રેઝન્ટ કરતા હતા ને કઈ ઇન્સ્ટોલ બી કરતા હતા બે કેમ
ખબર નહીં મારો બી નથી કોમ્પ્યુટર એની જાતે જ કઈ ચાલે છે.
એ ઇન્સ્ટોલ શું થતું હતું હમણાં વચ્ચે જે પોપઅપ આવ્યું હતું
Coming to main part, echo. Echo, to start with, there are 2D imaging. પછી pulse width Doppler.
ECG ને
ECG માં કઈ નથી સર. Biatrial enlargement, low voltage complex. બાકી બીજું કઈ ECG does not help in this case.
but in case you should mention
Yes.
એવું સાહેબ કહેશે
Okay.
કોન્વેક્સિટી આવે ને
Convexity.
ટેકિકાર્ડિયા આવે
Yes. Atrial fibrillation.
ફિઝિશિયન માટે કઈ
So first is 2D imaging, પછી pulse width Doppler, પછી tissue Doppler અને પછી speckle. So color also does not help. So color, non-colored, it's fine. 2D imaging. Constrictive pericarditis, ventricular wall thickness is normal. Pericardium thickness is more. Number wise, more than 3 mm on transesophageal echo is both sensitive as well as specific. There will be septal bounce. Septal bouncing is respiratory movement of IVS towards the left ventricle. And there is marked dilatation and reduced collapse of IDC and hepatic veins. Worse is the restrictive cardiomyopathy. Because of this is the myocardium. The myocardial wall will be thickened because of infiltration or because of some other etiologies. And there is marked by atrial enlargement. So this is a constrictive pericarditis echo. You can see there is thick and shiny pericardium. So this is our thickened pericardium, which is again calcified. This is thick pericardium, calcified pericardium versus restrictive cardiomyopathy. There will be huge or gross biatrial enlargement. This is also called as owl's eye appearance. While LV and RV remains either normal or it will be remain smaller in size. And if you look at the septal thickness, septal thickness is definitely much more as compared to normal. Look at the septal thickness here, and this is septal thickness. So this is typical of restrictive cardiomyopathy. This is typical of constrictive pericarditis. If we apply M mode to this, during inspiration, this septum, this is RV, this is LV side. So during inspiration, the septum moves towards L, and during expiration, septum moves towards R. If you look at normal echo, there will be smooth line, smooth wavy line will be seen. Versus there are multiple bounces seen in this. These are septal bounce, which is seen typically during expiration or early part of the expiration. If you apply this to a moving image, this is how it is seen. This is how septum will bounce. It will show a jerky movement. You see that there is jerky movement. This is not normal. This jerky movement can occur because of LBBB also, but LBBB does not give rise to kind of motion which is more towards the LV in inspiration and towards the RV in expiration. So this jerky movement with inspiratory movement of septum towards LV side, expiratory movement toward RV side is diagnostic of constrictive pericarditis. And if we look at from power chamber side, again this jerky septal motion is because of constrictive pericarditis. The apex gets obliterated. This is also very typical of endomyocardial fibrosis or Loeffler syndrome also sometimes. Again, diagnosis is biopsy. Unfortunately here no other than, but generally nobody does biopsy. If this kind of feature when RV apex is obliterated with eccentric jet of MR, biatrial enlargement, something like restrictive cardiomyopathy type of picture, it is diagnostic of endomyocardial fibrosis. Unfortunately, treatment remains same. You have to treat diastolic dysfunction and diastolic pain. Now, Doppler flow assessment. From here we can differentiate more, much more. In constrictive pericarditis, RV and LV inflow shows prominent E wave due to rapid early diastolic filling because it is not a disease of myocardium. So ventricle will relax during early part. In mid diastole, there will be restriction of ventricle filling because of the thickened pericardium, and so there will be sudden stop of ventricular filling. So there will be prominent E wave due to early diastolic filling, followed by short deceleration time because there is sudden stoppage of ventricular filling. There will be small A wave because the atrium will contract, but ventricle does not have capacity to take that kind of blood. So EA ratio will remain more than 2. Versus in restrictive cardiomyopathy, suppose a disease of myocardium. So in myocardium, E wave velocity will be decreased in early disease. In late disease, again E wave will become more. So it's a typical of diastolic failure pattern or diastolic dysfunction pattern. In early disease, there is restrictive filling. In late disease, there will be diseased myocardium.
Yeah, but early phase you can never judge.
No, you can never judge. You have to remain dependent on velocities.
Yeah.
So that is this. In constrictive pericarditis, enhanced respiratory variation in flow velocities because there will be ventricular interdependence. More than 25% increase in respiratory velocity in mitral side and more than 40% increase in respiratory velocity on tricuspid side is diagnostic of constrictive pericarditis. I'll come to images of this. Versus restrictive cardiomyopathy, here the velocities are decreased because the filling is decreased because of disease of myocardium. So velocity varies less than 10%. Before going to this kind of echo, we have to first optimize the echo. We have to have a respiratory graph in our echo. We have to have a ECG gate in our echo. So this two has to be there. And this respiratory graph has to have a gain. So respiratory gain has to increase so that we can differentiate what is inspiration, what is expiration. And we have to increase the sweep speed. If we have complexes so far apart and we have only 3 complexes in our screen, we cannot compare what is inspiratory, what is expiratory. So we have to have multiple complexes on our screen. So this should be how it should be there. If we look at this, there is marked variation. If you look at here, the E wave is so tall, then gradually it will decrease. Again it will become tall, again it will decrease, again it will become tall. So this is the respiratory variation. This is applied on mitral side. If this variation is more than 25%, then this is diagnostic of constrictive pericarditis. Versus restrictive cardiomyopathy, all E wave or all complexes remains more or less similar size.
Respiratory dressing છે ને કે પિક્ચરમાં કપાઈ ગયું છે?
Respiratory નથી, આમ apply નથી કર્યું. Unfortunately, આ મશીનમાં respiratory dressing છે નહીં. So that's why આટલા narrow complex કરી દો ને પછી respiratory dressing હોય કે નહીં ચાલે.
ના, but તમે
Maximum
ડોક્યુમેન્ટ કરતા હોય તો
minimum.
હોવું જોઈએ.
Yeah, હોવું જોઈએ. But definitely this respiratory variation is significant.
કેટલા percentage છે કાઉન્ટ કર્યું છે?
This was more than 25%. અને આ count કરીને this is more than 25% variation on mitral side.
એટલે highest જે છે એ 1 સુધી દેખાય ને lowest છે એ I guess 6-7 સુધી દેખાય છે.
1.2 and this is lowest is around 0.6. So it's almost 50% variations. Versus restrictive cardiomyopathy, it is similar.
Why it is needed? કારણ કે inspiration પછીના પહેલા બીટમાં જોવાનું છે.
નહીં, ideally end of expiration એટલે જેવો expiration થઈ જાય પછી જે નીચે ગ્રાફ છે ને એ જોવાનો છે. એટલે આમાં હું બતાવું. આ ઇન્સ્પિરેશન પીક પર આવે ને, so અહીંયા જે પી વેવ આવે, ઈ વેવ આવે એ કેલ્ક્યુલેટ કરવાનો. એટલે આવો કોઈ જે ઇન્સ્પિરેશન સ્ટાર્ટ અને એક્સપિરેશન પછી કે અર્લી એક્સપિરેશન ફેઝમાં જે ઈ વેવ આવે એને કાઉન્ટ કરો. આ પણ મોર ઓર લેસ સેમ જ છે. બધા ઈ વેવ કાઉન્ટ કરવાના. મશીન will sometimes also give you what is the ratio and what is the difference. So if your machine is smart enough, it will give you.
Put it, calculation મૂકી શકો અંદર.
Yes. Otherwise ના machine ના આપે તો જાતે કરે. Pulmonary venous Doppler. In constrictive pericarditis, pulmonary veins are outside the pericardium, so pulmonary venous Doppler remains normal. While in restrictive cardiomyopathy, it's a disease of myocardium. Ventricles are not relaxing, so pulmonary venous systolic flow is blunted because pulmonary veins are not getting emptied enough and diastolic flow is increased. Hepatic vein, I already said there is diastolic reversal. Low hepatic velocities will be there. There will be decreased expiratory diastolic hepatic vein velocities with large reversals will be there because of fullness of iris. So this is expiratory reversal. Generally in pulmonary hepatic vein, this kind of positive wave is not seen. If it is seen, it is diastolic reversal, and that is because of some diastolic dysfunction. Although in normal diastolic failure also, post MI, small diastolic reversal can be seen, but not so prominent. To be precise, if it is more than one, it is
Any
prominent.
cause of
diastolic
congestive
reversal.
heart failure, it will be so.
Yes, any kind of congestive heart failure, it will be seen, but more than one or prominent or tall diastolic reversal is going towards the diagnosis of restrictive cardiomyopathy. After advent of tissue Doppler, this kind of parameters are very easy to maintain. Now what is tissue Doppler? Tissue Doppler basically measures the velocity of the tissue. Till now we were measuring velocity of the blood across the mitral and tricuspid valve. Now what tissue we are concerned about? We are concerned about lateral mitral annulus and medial mitral annulus. In general, both mitral annulus moves. A normal value of mitral annulus velocity is more than 8 cm per second. In restrictive cardiomyopathy, now restrictive is a disease of myocardium. So myocardium movement is reduced. So both the velocity, medial velocity as well as lateral myocardial velocity will be reduced and it should be less than 8 cm per second. Then it goes towards favor of restrictive cardiomyopathy. In constrictive pericarditis, what happens? The longitudinal movement remains intact initially. We are worried about horizontal movement because of the thickened pericardium. Horizontal movement will not be there, but longitudinal movement remains intact initial phase of the disease. After advanced disease or after mid disease, there is adhering of lateral myocardium or lateral mitral annulus to the pericardium. So lateral mitral annular velocity will decrease. Although medial mitral annulus velocity will remain intact. So medial mitral annular velocity will be more as compared to lateral mitral velocity, and that is called annulus reversus.
So you should demonstrate on image for majority of
Change. How's that? So restrictive cardiomyopathy. Now we call this as the E prime. Tissue velocity is E prime and blood velocity is E. So E prime is decreased as the severity of disease increases. E prime less than 8 is diagnostic of restrictive cardiomyopathy. Versus constrictive pericarditis, E prime remains normal or increases because of vigorous longitudinal movement. Annulus reversus occurs. Normally, lateral E velocities are more as compared to medial velocities, while in constrictive pericarditis advanced stage, medial E dash velocities will be more as compared to lateral E dash velocities. What is annulus paradoxus? Here both parameters will get included. E by E prime. It paradoxically improves with worsen in constrictive pericarditis. Why? Because lateral E dash velocity decreases. So once lateral E dash velocity decreases, this ratio, if E dash decreases, the ratio will definitely increase. So that is annulus paradoxus. Generally, tissue velocity is less, blood velocity is more. So that's why annulus paradoxus will occur in constrictive pericarditis. So this is in constrictive pericarditis. This is medial mitral annulus velocity. This is E prime of 15 versus lateral mitral annulus of 12. So that is annulus reversus. Medial E prime is more as compared to lateral E prime, goes in favor of constrictive pericarditis. All E prime less than 8 goes in favor of RCMP.
Classical है आमा A prime तो छे
A prime change. And generally this kind of picture are seen even in early diseases. This kind of picture is very common. So after advent of this tissue Doppler,
टेक्स्ट बुक છે કે તમારો કેસ છે
नहीं यहाँ जाते हैं पोतानु. So things has been easier. Furthermore, spectral tracking. In constrictive pericarditis, the myocardium remains normal, so longitudinal strain will remain normal. But circumferential or rotational strain is impaired because the heart is not getting space to get dilated. Versus restrictive cardiomyopathy, longitudinal strain is impaired. Some apical rotational strain remain preserved during initial phase of disease. Late in disease, all strain will be reduced.
so that can be one of the reason of such question apical sparing they are more of a
Initially, apical sparing will be there in amyloidosis as well as all RCMP. So this is constrictive pericarditis. This is the various lines applied to various level. One is this yellow, blue, green, pink, blue. So all are having normal contraction. All are having normal longitudinal strain in constrictive pericarditis. Versus apical strain is impaired.
ऊपर
Longitudinal strain remains patent or remains normal. Apical strain remains absent. While in restrictive cardiomyopathy, longitudinal strain goes haywire. This yellow line or basal septum goes upside. This red is there, green is there. So there is dysynchrony in restrictive cardiomyopathy. Beta disease of myocardium. Cath evaluations I am not going into detail, but generally in cath evaluations there are square root signs seen. Square root sign is basically early diastolic filling that is very rapid, followed by a blunted phase, and that gives you a square root sign. But nobody does cath in a era of
another
advanced
supporting finding would be in which disease you will see mitral and tricuspid regurgitation probably
Probably in restrictive cardiomyopathy.
restriction. Generally, is constrictive you will never.
Constrictive, no. Cath generally people does when they are planning for cardiac biopsies. Then only cath is being done, or otherwise as a part of academics. Otherwise, cath is not being done because we have many other things which we can do. We can do CT scan or MRI also, which is also very easily available. But we have to tell our radiologists that we are not looking about coronaries and we are looking about pericardium. So then only they will give you pericardial thickness. Otherwise, they will always give you coronary. So CT scan provides detail of pericardium thickness. MRI also sometimes helps us by giving inflammatory process by late gadolinium enhancement. And MRI can detect infiltration in case of restrictive cardiomyopathy. Pro-BNP, yes, it is obviously elevated in case of restrictive cardiomyopathy. Generally, it remains normal in constrictive pericarditis. Endomyocardial biopsy only applied to be in case of amyloidosis or infiltrative cardiomyopathy when the diagnosis is not sure. So if you look at the ACG 2015 echo criteria for diagnosis of constrictive pericarditis, there has to be jerky septal motion, there has to be restrictive mitral flow velocity which has to be variations, hepatic diastolic flow reversal has to be there, medial E dash should be 12 at least and lateral E dash should be 6 at least, and there has to be annular velocity or annular reversal. And this is to summarize. ECG remains in normal. This is the ECG in restrictive. There will be low voltage complex constrictive. Although ECG does not help much. Mitral valve velocity remains similar in case of restrictive cardiomyopathy. It varies by 25% in case of constrictive pericarditis. Same with tricuspid velocity remains similar in case of restrictive cardiomyopathy. Varies by more than 40% in case of constrictive pericarditis. Hepatic vein will show prominent diastolic flow reversal in case of constrictive pericarditis. And obviously tissue Doppler also is the diagnostic. So hope it was not a boring meeting. Treatment part doesn't remain much because treatment part is we have to treat failure and after that failure, if at all it is constrictive pericarditis, it is treatable condition. Prognosis is much better as compared to restrictive cardiomyopathy if we can remove that constriction. So that's why it is more important to differentiate. Now let's